Get 6 months of local news for just $2. You get unlimited access to the news and information you need to stay connected to your community. Visit inforum.com/subscribe to get 6 months of local news for just $2.
You're listening to Plain Talk, the voice of North Dakota politics. I'm your host, Rob Port. If I sound distracted, it's because I've been busy covering this story all morning. I'm joined by my co-host, Chad Oban.
He's right of center, I'm left of center, both sides of the political spectrum.
I think it's cathartic. I think it's a necessary and proper debate. I'm glad we're having it.
And honestly, we have to do better.
Okay, I don't know why I'm getting blamed for this, right? Oh, Matt had to hit record real quick to start getting some. We had the baseball smack happening here in the beginning of the show. Chad, as the audience well knows, is a Dodgers fan. I'm a Yankees fan. Our guest, Tim Blazel, outed himself willingly. We didn't have to beat it out of him or anything. Admitted to being a Boston Red Sox fan, Tim.
Yeah.
Now,
it's so cute, you guys waiting for spring training. I mean, some teams are still playing this year.
Yeah. Well, if only our governor was here and we could dunk on him for the Mets.
Yeah.
Collapsing towards the end of the season, as Mets are wont to do.
Yep.
You know, it's not even that odd a thing. We didn't bring Tim on to talk about baseball, although we could. We could. And I will. Chad is so touchy and he's so mean to the Yankees. I am always such a gentleman to you about the Dodgers. I like the Dodgers team. That pitching performance last night.
Unbelievable.
Going 9 innings. Fantastic. I love Frank Freeman. I love Mookie Betts.
Yep.
I love Kike Hernandez. Is one of the great baseball personalities of our era. It's a great team. I hate it when they beat the Yankees, but I don't hate on the Dodgers.
So here's the thing. I don't like to go over the top, like with too much crap talk during the season, but I do like to do little zingers. I have a friend who's a big Brewers fan, and he was in Milwaukee for game 1, and he had really good seats. And at one point, he was on national TV with his face in his hands. And I recorded the thing, and I showed him enough respect to not send it to him until the next morning because I feel like he needed a little bit of time. But baseball is a stressful, wonderful thing, and I don't think there's anything more stressful and great than October baseball when every pitch matters. It's beautiful.
It's great when you win. Breaking when you lose. I mean, there's for all that, like the controversial political topics that I navigate. I'm used to all that. I am sensitive about baseball, man.
And it hurts in a different way.
Yeah, and I was a long-suffering Red Sox fan until about 2004. So I became a Red Sox fan in the mid-'70s when they played the Big Red Machine, and so it was tough there until about 2004. It's actually been tough since about 18, but hopefully we got some young guns coming up, so hopefully we'll become competitive again here.
Hope springs eternal.
Yeah.
We bring you on to talk baseball. We brought you to talk about the cost of healthcare, which I'm sure everyone just loves talking about.
Yeah.
We actually had a couple guys turn into a running, for no intention of ours, kind of turned into a running topic, vitally important, and sort of spawned obviously by what's going on in Washington, D.C. It was a big debate over the subsidies or premium subsidies for Obamacare, Affordable Care Act policies. And our insurance commissioner, John Godfread, basically warning if these aren't put in place, it's going to be dramatic premium for a lot of North Dakotans, a lot of Americans. That's the insurance side of things. You represent the care side of things. It's the hospitals, you guys employ the doctors, you provide the care when we get sick. And obviously, part of when we talked to our insurance commissioner, John Godfread, he referred to kind of a finger pointing match between the insurers and the care providers over cost. The insurance industry wants to blame the hospitals want to blame the insurance industry. My argument is Americans are scared. North Dakotans are scared to go to the doctor. When one of my kids gets sick, that's the first, as a dad, obviously I'm concerned about their well-being first and foremost, but I'll tell you, like 1A on my priority list is what is this going to cost me? I am terrified to take my kids to the doctor because I don't know what the bill's going to be. how do we navigate that right now? I mean, I think we had a guest on last week, Chris Jones. I know you said you listened to the interview. One of the things he's talking about is like price transparency. I think that makes a lot of sense, but how do we get our hands around these costs, Tim?
Yeah, no, I mean, it's a great question and it is a huge concern. We get into price transparency, there is a CMS requirement for that now. And so hospitals are required to post their charges online, and also it's all their services. And then also I think their most common shoppable services. And so, but I don't believe that's going to bend the cost curve. Again, I think we need to define, prices versus costs. Prices, yes, there's a charge that we charge, obviously, the patients that come through the door. What I want you to understand is that typically we don't collect those charges. I would say 90 to 93% of our payments that we receive, whether it's from the federal government and CMS or state Medicaid or commercial, those have been sort of predetermined already. So even though we have a charge, we are not collecting what we charge. Again, that cost for the consumer. And I agree. I mean, healthcare is expensive, and it's expensive for the consumer. It's expensive for the provider. But again, when in terms of hospitals and physicians, again, if one hospital charges, and again, I'm going to try to make this simple, but if one hospital charges $1,000, the next one charges $2,000, that cost to the consumer, for the most part, if you have insurance, is going to be the same. So again, for us, in terms of, we spend a lot of time talking prices. Typically hospitals don't collect prices. We do have to establish a charge. But again, if you have insurance in this country, you are not paying what that charge is. You're paying that part of that negotiated rate that's been determined between the payer and the provider. And, and again, I agree with Chris Jones in his statement last week, or I think he mentioned it once or twice, that healthcare is complex and it is expensive. And I know that my members, the association, we're trying to spend time talking about how do we reduce costs. We can talk price transparency, but how do we focus in on the cost piece? And, what should healthcare look like? Now, I have some of my own thoughts, but again, that's what we got to focus in on. So again, patients shouldn't be concerned about, and I get it, it's expensive. And I know we have some people that are focused in on what it's going to cost. I mean, I have a family. I'm concerned about that as well. So, but I just want to be kind of transparent in terms of, you hear all these discussions on hospital prices. Typically, we do not collect what we charge.
So, Tim, one of the things, I mean, if you've listened to any of the recent podcasts, you know that I'm frustrated with the cost of healthcare and health insurance. And part of me as a consumer and somebody who's in charge of employer that pays for health insurance for 25 of our employees. And I represent teachers who are negotiating health insurance, which is the biggest cost in the district. I hear you, I hear the insurance companies, and sometimes I hear what seems like you guys are just trying to protect your business model. That is working because that's what we sort of do. And, to hear it's complicated. Yup, it's complicated. That doesn't help me. That doesn't help me as a consumer. Why can't the hospital association and the insurance companies sit together? Because it does feel like, no, it's their fault. It's their fault. Here's the deal. I think the hospitals have a role. I think health insurance companies have a role. And I think Congress has a big ass role in this thing. And at the end of the day, those three groups are making decisions and the consumers are being hurt. Yeah. So how do we move the ball forward? If it's not more transparency, how do we move that ball forward? So we're thinking about when Rob takes his kids to the hospital, he's thinking about just about his kids' well-being, not about what that check is going to look like when he has to write it.
Yeah. No, I think you're absolutely right. I think communication, getting together is key. I think, one nice thing that we started in the state here last interim session was the healthcare committee. It brought together, hospitals, it brought together physicians, it brought together the payers. And again, whether it was, Blue Cross here in the state or the Sanford Health Plan, it brought together legislators to start, having those discussions on what we can do, at least in the state. And so, those are some great discussions. In terms of, we had a lot of discussion about, how do we prevent, I think the big piece, I think in my mind, if you're going to change healthcare and try to reduce costs, I think is preventative services before it becomes chronic. I think that's one avenue. I think end of life is the big one. But again, just, my experience in terms of bringing people together, that's what we were doing last session. I think those discussions need to continue. But yeah, no, I agree with you. I think, to fix this and make it better, all the players, and when I say players, that are hospitals, physicians, you got payers, you got big pharma, you got the pharmacy benefit managers, the PBMs, all of that. We all have a part in this, and yeah, we shouldn't be doing any finger pointing at all. Again, we're in this all together, but to kind of fix this and talk about costs. I mean, you have to get people in a room and have that discussion. And again, I have to commend the legislators I think it was the 23-25 session when we talked about this in terms of bringing a committee together to start those discussions. So again, I think that was a kind of moving in the right direction. But no, totally agree with you that again, we need to bring people together to work on this.
One of the pushback I got from some people who work in your industry after our interview with John Godfread, and I followed up with an independent column based on some of the information he had shared with us, where his office had a secret shopper go around and found some pretty wild price disparities between Minot and Fargo and Bismarck and Grand Forks for pretty routine. I think it was a C-section birth, a birth, and a colonoscopy. Yeah. And just why it costs 300% more, 600% more, whatever the differential was I think it's really hard to understand. That sounds to me like a situation where prices are completely disconnected from reality. And then there's also the fact I think a lot of people have experienced this. I mean, I've looked at my parents' itemized medical bills. I've looked at my itemized medical bills. I see like a tab of aspirin costs $65 or something like that. And that just seems like is not tethered to reality. So can you speak to that? Because I got a lot of people say that the secret shopper thing specifically was not a valid metric. And maybe you addressed that somewhat where you said, because, we're negotiating with the government through their various programs. We're negotiating with the insurers through their various programs. A lot of times the price that gets paid for covered people is not the price. So maybe that renders this moot, but I don't know. Speak to that secret shop.
Yeah, you bet, Rob. Again, there's been some national stories done on this. Obviously I'm very familiar with the study, the health study that the insurance commissioner, did, I want to say maybe 5-6 years ago, and where there was some price shopping going on. Now, will prices be different? Yes. I think what people need to remember, and again, and maybe the insurance commissioner did ask these questions, but typically, again, before I've been at the Hospital Association here for about 17 years, but I used to be in the provider setting. And so I know how things work in terms of, revenue and things like that. Now, again, when people price shop, and, again, hospitals have been providing prices to consumers for years. I mean, this is not something new, but again, let's just say I'm going to use an example, like back to your C-section. You're going to have that individual, that female is going to come to the hospital. There's going to be a physician involved. There's probably an anesthesiologist involved. There could be a radiologist involved. And all those services are billed separately to insurance companies. They're not all on one claim. And so when you do some price shopping, you need to make sure that you're comparing apples and apples. And so if I come I'm just going to utilize Sanford Health here in Bismarck, and you call and, hey, what is the normal charge for a vaginal? Okay, they're going to give you a price quote. Okay, well, we need to make sure that includes all those other players involved. So if Sanford Health does, and I'm just going to throw out a number, if that is $10,000 and now you call Altru, and you just get the hospital component, it is going to be a lot less. So when you do some of that shopping, you have to make sure that you're asking the right questions. I'm not saying that the insurance commissioner's office did not do that. But again, when I see those kinds of differences, Rob, those are some of the questions I have to make sure that when we're doing some of that shopping, we're making sure we're asking the right questions and we're comparing apples to apples.
That's fair. I don't know. I don't know the methodology for that.
Yeah. Just
But
kind of going.
because I guess that makes sense. Where if you ask Trinity Hospital in Minot, which is where I go, and they're these, well, how much for a knee replacement, and they quote you a price, but they don't include the anesthesiologist or the radio or all those other specialists. I guess that makes sense. But why are they all billed separately? Because when I go to Trinity, the radiologist works for Trinity, the anesthesiologist works for Trinity, and that thing, when I'm trying to sort out how much a thing costs me, and I have like 5 bills from 5 different divisions of Trinity, and it's like, why can't I get one bill?
Yeah, no, it's a requirement. So again, when we go and bill the insurance companies, though there's separate claim forms for those different types of services. And so, yes, I mean, I'll give you an example. Back in the day, I used to work at a bigger health system here in North Dakota, and we did not employ our own, say, cardiologist. We didn't employ our own anesthesiologist. But if you came in for a procedure and each of those individuals touched on that care, those separate groups would bill separately. It is confusing to the patient. It is, because they're getting bills from, 2 or 3 other individuals or groups. And so when you do your price shopping, you got to be asking the right questions and making sure that you're capturing everything. So again, like I said, back to my example, you may call Sanford here in Bismarck and they may give you a bundled price. You may call another hospital and they may unbundle that, if that makes any sense. So I think when I see those big variations in terms of price shopping, that's the first thing that comes to my mind, that did one hospital bundle and the other one didn't. So you just got to be, and like I said, I know those differences. I've seen those differences that the insurance commissioner had in his report. And I'm not saying they're wrong. I'm not saying that at all. But I'm just saying, with those kind of differences, those are questions that, pop up in my brain.
Again, I worry about the consumer in this whole thing. I mean, Tim, you mentioned several times there, you got to know to ask the right question. There's no way a consumer is going to know to ask the right question at every one of these hospitals. I wish the healthcare providers would just all use the same system when they're telling people what they're paying for. But that's not my question. I want to talk about financial transparency. Obviously, the insurance companies have to provide the insurance commissioner with their financials when they're looking for rate increases and that kind of things. One of the things that John Godfread talked about on the show is that we don't see that same level of financial transparency from hospitals. I mean, I know that hospitals do their 990s, but it's not necessarily an individual hospital. It's more of the big system. And as our systems are getting bigger, it's even more difficult to figure that out. So how can we figure out like what we can do if one side of this equation has to provide all their financial information, and then the healthcare system has a different way of reporting that financial information? They have to dig through and sort of figure things out. It just doesn't feel like, if we're not comparing the same things, that we can figure out. Again, we don't want to point fingers, but we need to have the data to make decisions on what's going on here.
Yeah. Again, in terms of within the state having a requirement to provide that information, right now there is not that requirement. Now, again, we work with our members to pull a lot of that financial information and, provide that, during a legislative session, things like that. But I also want to point out that, you mentioned the 990, but also each hospital that participates in the Medicare program has to fill out a Medicare cost report every year, and that is public information. And so that information can be, requested through the Freedom of Information Act. But every year, hospitals have to put together a cost report, which again consists of all their revenue, all their contractual allowances, all the discounts that they take from either patients or provider or payers, all their cost components, all their financial information is required by Medicare. So a lot of that information is public today. There's probably not a lot of people that are aware of it, but a lot of this information does get published through different consultants, throughout the country. So there is a big, huge document that hospitals have to put together every year to provide this information to the federal government.
Tim, you said the state doesn't currently require this. Should the state require this?
Well, that's something we're working on. Again, I'm not saying it's shouldn't be required, but it's something we're working on here at the association to sort of create a database to have all this information gathered and, obviously supply it to, individuals that, legislators, things like that, different committees that would want to see it. So again, there is, and again, and I think that in a lot of other states, it's probably not a requirement. But again, there is no formal process right now in terms of supplying financial information to HHS, things like that. I think a lot of times they're using 990 and Medicare cost reports to get to that information.
Sorry, Rob, one more. But so, Tim, you're telling me that the hospitals have this information. So if the state required it to be brought to the state, they have that information already. So it shouldn't be too big a burden for hospitals to provide that information to the state.
I think the state would have to do a little bit of digging to get to it. Again, they would have to, file a request to get to, say, a Medicare cost report. Again, it's not a requirement today in terms of a state requirement. If it was, we would comply, but, that's not.
But I guess, Tim, my question is, if the state were to require it, what I'm hearing you say is that the hospitals already put this information together for other things, so it wouldn't be a big burden on individual hospitals to put together this information to provide to the state if it were required.
Correct.
Okay.
Yep.
I wonder, we talk so much about price transparency, and I do think that's important. I think when you see prices spiraling the way they have, and certainly when you have a situation, there's some pretty famous charts about inflation for things, and like higher ed's obviously way up there, but number one are healthcare costs.
Yeah.
Which some of it's, we can do more stuff medically, right? It's not a doctor showing up at your house with a black bag anymore. It's very complex, and all those medicines and technologies cost money, both in terms of developing the technologies and buying the machines and training to use them appropriately. So I get it, and that's driving some of it. But I wonder if price is everything in this, because when we talk about, okay, well, the government has all this data and people can go look at this data, but when someone's really sick, they're just going to go to the hospital. I live in Minot. I think there's a couple other clinics or whatever, but for the most part, if it's a serious thing, I have one place I can go. Plus I'm willing to drive to like Bismarck or Fargo or something.
Right.
And so, I think price transparency is only going to get us so far. From the hospital side, you said you guys are interested in or looking into driving down prices. What are your ideas? What do we need to do to get prices lower?
Yeah, again, it's that's a great question, Rob. Again, I kind of go back to what we experience in the hospital setting. Again, I think the major driver that's increased, again, whether it's the last 10 years, are pharmaceuticals. It is, we have these great drugs that come out. Well, there's a price tag on those, and it's expensive. And I think, outside of probably, just to kind of give you an idea, is that in terms of hospital expenses, I would say roughly 60% of those is related to salaries. The other component, are supplies, and obviously pharmaceuticals are one of those supplies. I think if we could get some sort of, I don't want to call them caps, or get our arms around the increase in the pharmaceutical business, I think would help drive down costs. And so I think that would be where I would want to start in terms of trying to bend that cost curve. Because again, price transparency is, and again, this is my personal opinion, there is a CMS requirement today. The state wanted to make it a requirement, back in the last session. And that we felt was just another layer because it mirrored what the federal government was doing.
Representative Jared Hendricks' bill?
Yes. And, again, we totally support price transparency. We support,
Well, I was going to ask, what was the specific argument against that legislation?
Because it was mirroring what CMS requires us to do today. So if you look at what that bill required hospitals to do, it's the same thing as what CMS requires us to do today. And that is, having available to the consumer a list of all our prices. And, there's, the federal government audits hospitals, there's civil penalties. And at the end of the day, the state, again, Representative Hendricks' bill would have done the same thing. So we just felt like it's a federal requirement now. Why should we be spending state dollars to monitor it on the state level when the feds do it already?
Tim, one of the things that I think all North Dakotans should be concerned about is access to rural hospitals, right? I mean, one of the real quality of life things that we have in the state is making sure that you can access healthcare. And I think, people don't talk enough about Can-Do and some of these other places that are really providing great services, but it's really expensive to also do those things. And one of my concerns not concerns, but one of the things that, we had during Obamacare, we had the Frontier Amendment, right, to take care of rural hospitals. And now during the big ugly bill, in my opinion, some people call it a beautiful bill, there's a big chunk of money again for rural hospitals to protect them. I worry that when we do these carve-outs to get people's votes or whatever, it just makes the whole system more complicated. So recognizing we need rural hospitals, but also I'm not sure that's the best way to do legislation. Can you just comment a little bit on sort of these federal programs that help protect our rural hospitals and that type of thing?
Yeah, again, at the end of the day, especially in the rural areas, they want to keep access to care in those communities because typically, in those rural communities, the biggest employers are typically hospitals and, the school.
Yep.
And so I think Medicare did a great thing probably about 25, 30 years ago when they created a provider type, which is called critical access hospitals. Okay. And so the funding or the reimbursement for those services is different than urban hospitals. It really is almost kind of covering 100% of their costs. There's a few things carved out, but it allowed these hospitals in rural communities to remain open. I'm very optimistic in terms of the funding that came out of the One Big Beautiful Bill or just the One Big Bill in terms of the Rural Health Transformation funding program. Now that is being, discussed here in Bismarck. It was discussed yesterday and today. I'm going to go up there this afternoon, but, how is that money going to get distributed within the state? And so I think, in terms of getting some funding into the state to help rural communities is critical. So, we have roughly about, in terms of general acute care hospitals, about 36 smaller hospitals in the state. We haven't had any closures like other states. I think, back with the ACA and us expanding Medicaid really helped keep some of those doors open in the rural communities. But, again, I think some of the things that have been with the critical access hospital provider type being created has really kept the doors open in a lot of these rural communities. So, and again, when decisions are being made in Washington, because we're working with our congressional leaders all the time. So what makes sense for Texas or California or New York, a lot of times doesn't make sense for North Dakota or, us frontier states. And so we need to keep our legislators, our congressional leaders up to date on that. And, sometimes those decisions in Washington don't make sense for us. And so we try to keep we monitor that very closely.
That seems to be a lot of what our delegation does when it comes to federal insurance or healthcare policy is to try to get carve-outs for North Dakota to exclude us from it because, and I'm sure that's not unique. I'm sure Ohio has challenges in Illinois and Texas and Missouri, and they all have different challenges that are specific to their states or their regions that make this difficult. This is a tough thing, the price thing. And again, I think at the end of the day, I think there's a lot of people who feel like I do, where they're scared to go to the doctor because they're scared of the bill. Yeah. And that's a terrible place for Americans to be in. I think in a lot of ways, one place where your industry should be commended is I think we have the best healthcare in the world. Yeah. There are people who travel from around the world to come to the United States to enjoy the innovations that we have and the expertise. There are people who want to be doctors who travel from around the world to want to be doctors in America. Yeah. The innovation and the expertise is. That's a great, not to look down our nose at the great things happening in other countries, but America's a leader in this area. And that's
yeah, and I agree with you, Rob. And I think we can be proud of the healthcare we're providing in the state of North Dakota. Yes, there is, a price tag on that. It's not cheap. But, again, we provide great quality healthcare here in the state. And, and my members are, want to keep healthcare local. They're doing whatever they can to, keep, again, I'll just use, I just got off the phone with the CEO in Grafton. And so he's doing everything where he can keep that local community coming to his hospital instead of having to travel, whether it's to a Grand Forks, Fargo, or Minneapolis. And so again, I think we're providing great health care in the state. I think you can, travel anywhere in the state and get great care. So, but yeah, I mean, it is, not cheap. But, again, I think when I talk to people a lot, we take a lot of calls, again, somebody was in, they got an itemized bill. Why is the charge so high? I try to educate them that, again, a lot of times, in terms of what you're trying to determine on what it's going to cost you, is, working with your insurance company. I think our uninsured rate here in North Dakota is roughly 8 to 10%. We're very fortunate. It's higher in other states. And so again, when you get into the hospital finance piece of things, is that, yes, there is that charge, but again, hospitals in terms of their budgets have to work within, probably 90 to 93% of their payments fixed. And so again, when they're doing, yes, there is the charge, but we don't actually get paid that charge. We get paid from the insurance company.
Does that explain why some of the oddball, like some things that are, because the price is fixed on certain things, they make it up on other things? Like maybe that's why aspirin costs $65 a pill or whatever.
Well, Rob, I would really like to see an itemized statement where there's a drug, an aspirin or whatever that costs $65 because, again, if I'm not aware of anybody charging 65, but again, we are sensitive to, again, if you can buy it over the counter, then the price should be somewhat in that ballpark or maybe a little higher. Again, the thing is that I get asked a lot, well, why does, back to your example, for a pharmaceutical item, I can get it downtown for $1, but I go into the hospital and it's $25. There's a lot of the direct cost is the actual purchase of that drug, but there's a lot of indirects that go into the pricing of it. Again, we're open 24/7, 365, things like that. There's a lot of indirects that go into the increase in that charge. But like I said, again, if we're sensitive to that because, hospitals aren't, buying pharmaceutical items, CT scanners and marking prices up 500%. That's not how it works. Again, we could do that, but at the end of the day, we're not going to collect that dollar amount because I'll just use Blue Cross Blue Shield. If there's a CT procedure and what's been negotiated between Blue Cross and the hospital is, say we're charging 500, but the negotiated rate is 200. That what we're collecting from both Blue Cross and the patient is $200. That $300 is just getting discounted. So again, I think people need to understand how hospital finance works. Yes, there is a charge, but the charge typically is not what is collected.
Last question, and I mean this puts you on the hot seat a little bit, but increasingly we're seeing where healthcare providers are also the insurers. And I got to tell you, I'm worried about that vertical integration because I don't know that I want my doctor to also work for my insurance company. And I know the people that are doing it, Sanford's the big one in our region. I know what their argument is, that there's a bright line between these two. And maybe you'll forgive me if I'm not persuaded that that's necessarily true in practice. But what do you think? I mean, that seems like that vertical integration seems like an emerging thing in your industry. Is that good? Is that going to solve this, or is this going to make everything worse?
That's a great question, which I don't think I have an answer to. I think, again, if it's going to reduce healthcare costs for, say, the consumer, obviously I support it. So again, it's just, I don't have a lot of background to answer that question. I'm not trying to dodge your question at all. I mean, it's tough to answer.
Wasn't squarely on what we invited you on for, but it's my mind, and that's kind of what we do here on Plain Talk is very free form. I appreciate you coming on though, Tim.
No, I appreciate the invite, and again, if you want me back in the future, feel free to reach out to me.
Going anywhere?
No,
I'm kidding.
No, it's a complex issue, and I wish I had all the answers. I don't, but understand that in North Dakota, we're all trying to bend that cost curve, and how we go about doing that, I don't think it's a little bit of everything. I don't think there's this huge idea out there that's going to solve all this. I think we just need to chip away at it.
Thanks for your time.
Thanks, Tim.
Hey, Plain Talk listeners, have something to say? Call or text Plain Talk with your questions, comments, or headlines you want us to cover.
Just dial 701-587-3141. Leave us your message or shoot us a text with your name and location, and you could be featured on an upcoming show.
Hi, my name is Ashley, and I am in Jamestown.
Hey, Rob and Chad. My name's Tony. I live in Grand Forks.
That's 701-587-3141.
Call us, text us, vent, praise.
We want you in the conversation. Thanks for being part of the show.
Now let's get back to today's episode.
Welcome back. Just got done talking baseball and also health insurance. I'm really kind of proud of us, Chad, because we'd had somebody on from every side of this. Really. I mean, we haven't had
the insurance companies yet.
We had the insurance commissioner.
Right.
Who I feel like in some ways was kind of making the insurance industry's argument.
Yeah.
But you're right. We haven't had but we had the government on, Chris Jones working at the federal level, Godfread working at the state level. And then we had Mr. Blazalon from the Hospital Association. And, again, I think there's more we can do on price transparency. And I think his argument against Representative Hendricks's bill was a little specious. If they're already, then it's not that hard to just send the state the report to.
Yeah, so that's what I was confused by, and that's where I was going prior to that, sort of you're saying the state doesn't require it, so we don't do it. So what if the state does require it? Will it be a bunch of work? And he said, no. Okay, then let's do it. And then later he said, we don't want to do it for the state because we already have to do it for the feds. Well, just hit CC on the email, Rob, and just include the state.
And he also said that to get some of what the state would want, you'd have to kind of go digging through the different Medicaid. Well, then I don't want to create a lot of extra red tape for any business in the state, let alone a business where the costs are soaring.
He said it wouldn't be.
I think it's that much red tape. I mean, I don't think it's that hard. So, but also, I mean, for as much as we're focused on price transparency, and I think there's some victories we can get there that would help, that's not a panacea.
No, of course not.
Most Americans access healthcare. And I'm not kidding, Chad. I'm sure you feel the same way as a child. Like your kid gets a cough or something, and the next thing you know, as a dad or as a mom, you're thinking, oh my God, we're gonna have to go to the hospital. What if it's serious? You're worried about your kid, but you're also worried about what's this bill gonna be. And I do that for myself. I will be honest with you. I don't go to the doctor nearly as often as I should have. I'm doing better now. But throughout my life, I have not gone to the doctor nearly as often as I should have. I have lived with sicknesses and illnesses where I probably should have gone in and didn't because I didn't want to pay the bill.
Yeah. Here's sort of what, I do think the consumer often gets lost in this thing, right? Because I do think it's a lot of, hospital finance is confusing. And if you do this FOIA request, this is public information. That's not what normal people do. It was several times. People need to understand hospital finances. I'm engaged in this conversation. I'm never going to understand hospital finances. I'm never going to understand them.
I don't need to understand auto industry prices to understand what a good price is for a car and how that fits into my household budget and the trade-offs between the type of car and how old it is and my budget. I mean, I can do my household budget, but I don't need to understand. I just need to know the cost of the service that you're going to provide me.
Right. And I think the other piece here, and it's what Godfread brought up. On one hand, he can regulate the insurance rate increases because he gets all their financials and whatever. But on the other side, he doesn't get to see that for hospitals, or nobody at the state sees that for hospitals unless you dig into the 990s or go to this report or this. We need to have both sets of books, right, to figure out sort of what the costing is here. I worry that there is a interest in keeping this complicated because there are a lot of people benefiting financially from the current health system. I'm not saying Tim. I'm not saying any specific hospitals. But this is complicated. And I think there's some people who want to keep it complicated. So people like me and the people I work with don't understand it.
That is why I wanted to commend them for the excellent care that we get. Because there's a lot of people working at these hospitals, working in Tim's industry, that are wonderful people, skilled people that are helping a lot of people, keeping people alive, reducing their suffering, keeping them healthy. And I don't want to lose sight of that either. And that costs money. And those people deserve to be paid for their time. You know, but on the other side, there is clearly a disconnect here. There is a disconnect when, you know, the tech industry can offer all the services it does, like this remarkable thing, and the prices are affordable. I mean, now I could complain about how many streaming services I have to subscribe to baseball season now. There's some problems there, but for the most part, the cost of cell phones, the cost of streaming services, all this technology we have has been kept relatively in check. Like the inflation rate on that industry is not high. Healthcare is through the roof. Something has gone off the rails here. I understand that healthcare it's got its own unique challenges, and it's evolved in a lot of ways, and we have to pay for that innovation and that expertise. But that doesn't explain it all. Something has gone off the rails, and I think you're right. I mean, if when Xcel Energy wants to do a rate increase, they have to make a case to the Public Service Commission.
Right.
When insurance company, you know, wants to raise premiums, they have to make a case to the insurance commissioner. Maybe hospitals need to make a case for price increases as well. And I, again, understanding that that's complex, but, you know, I mean, and the thing is, we're already doing it for one side of the equation. We're already doing it for the insurance companies, but we're not doing anything for the input, like what the insurance companies have to pay for. We're not doing anything on that front. Maybe it's time.
And the pharmaceuticals too.
Well,
sure.
sure.
I mean, that's the other thing that, I mean, I think Tim did an effective job of bringing up. It's not just the hospitals. It's also the pharmaceuticals that cost a ton of money as well.
And like the medical device industry.
Right.
There's now, that being said, the risk of price controls is that you kill innovation.
Right. And that's the problem, right? The reason why we have such good health care in North Dakota and around the country is because of innovation. I will say I'm so pleased that we live in North Dakota. My mother-in-law is currently 2 hours out of surgery for having her hip replaced this morning. And she will be in my home at 3:00 this afternoon recovering. Think about her quality of life is going to be so much better with the new hip.
Yep.
And she went in at 5:30 this morning. We'll be at home, our home, at 3:00 this afternoon. That's because of innovation. That's because our health system is so good. It's going to cost her a ton of money.
Part of what frustrates me about this debate is we say, well, why don't we just control prices like Canada does or like Great Britain does? Forgetting that these are international markets. And a lot of where these companies make up the price difference is in the American market. They can afford to sell at a cheaper place in Canada because they make up for it in the United States. So I don't know that just adopting Canada's policies, in a lot of ways, I would argue people in Great Britain and Canada and in these places where they have a lot more government controls probably are hoping that America doesn't do what they do, because we're the great pressure relief valve for the world on this.
Yeah, I mean, we obviously pay for the innovation that we get in this country, right? I mean, there's no doubt about that. You know, we've heard from so many different guests over the last several weeks talking about I feel like, by the way, I think health insurance is our new property taxes, that we're going to just talk about it consistently, but I think it's important.
It's hugely.
You know, to a person, people are saying, if we're starting from scratch, this is not what we would do. And we don't have the political will or whatever to just break it down and start over. And I think Chris Jones said you'd have two options, you know, a single payer sort of option, or, you know, cash payment on the other sort of fringes of how you'd build this system.
I think it's terrifying because the problem is while we hammer through that, we've still got to deliver the services in real time to everybody. And if we fundamentally change how it's paid, how do you, somebody who's been on, you know, Medicare, for instance, and paid into it their whole life? I mean, we don't want to we ought to tear down Medicare and Social Security and start from scratch too, because there's problems there. But everyone's terrified to do it. And especially because like Democrats don't want to do it now because Republicans are in charge of everything. So of course we don't want to tear down Social Security now. We're going to get the Republican version of it.
Right. Well, I'm 50 years old, Rob. I turned 50 in January. I'm not quite 50 years old. I don't want to be tearing down Social Security and Medicare right now. I'm about to benefit from this.
When I was 20, but now I've been paying into Social Security since I was 50 years old.
Yep.
So, I mean, I'd like to get at least my money back out of it
Yeah.
at some point. It's frustrating. And we're trying to do this in a country that doesn't, right and left don't talk to each other anymore. They don't trust each other. In fact, I mean, the president of the United States stood at Charlie Kirk's memorial and talked about how much he hates the opposition, hates them.
We have a government shutdown in Washington where the majority party of the House isn't even in town.
He can't pass an annual budget. And so the idea that we're going to tear down healthcare policy and start again from the studs is, I mean, I'd like to, and I agree with you that it's necessary, but how? I don't know.
You can't. I mean, it's impossible. But again, I think that what I heard is there should be a bill next session again that forces hospitals to provide their financials to the state, that it won't be any additional work for hospitals. And that's a start.
Progress on price transparency seems like something we can achieve bipartisan. I mean, I'm not a fan of Jared Hendricks, the lawmaker, or the political activist, but that bill was a good idea. And I'd be happy. I mean, he should be commended for it.
And maybe Jared, look,
I'm not saying that it's perfect as is and
right.
improve amendment. But
that's what I was just going to say. I don't know specifics about Jared's bill, and maybe it wasn't perfect, but rather than saying, no, we shouldn't do this because the feds already require it, maybe we need the hospitals to get in to figure out how to make this bill. If we truly want transparency, if we truly want fairness, this is a no-brainer for them to provide that information to the state.
And also given, the political realities, I'm honestly open to the idea of, maybe the hospitals have to bring their prices to a hospital commissioner, a healthcare commissioner, or something like that to get them approved. And they have to make, like Xcel Energy wants a 19%. They have to make a case. Like they have to submit a case and they have to justify it and say, this is the reason why. Maybe hospitals should have to do the same thing. And that sounds just radical to me, but holy cow, we have got to get these prices back to the
like under a normal like free market system. That would be radical and that'd be crazy. But how much of the government's paying for a big chunk of the services provided at hospitals?
Even what's privately paid is through a third party system that essentially, in a lot of ways, is ensconced in place by the government as well. I mean, if you're a employer, you don't have a choice really. That's the reality. And so much of our public policy and the tax code and everything else is built around that idea of employer provided health insurance. If you're an employer, you kind of don't have a choice.
Right.
So,
you're not going to be able to recruit and retain employees.
It's not a free market. So until we're going to rip it down and start a free market,
or start a socialist market,
I would prefer the other. But, until maybe we just have to impose some price controls on the status quo because something's got to give. Yeah. Or at least make the hospitals come into a room and submit a report on the record and say, this is why the cost of a knee replacement has to go up.
And just saying it's complicated isn't a good enough answer because it is complicated, but dumb it down for me.
We have smart people in government. We can figure this.
Right. Yeah.
The Fargo Davies thing at the school. First of all, that thing's going to grow. And I think it has ripped the lid off something that I think we all know goes on. My first column, being sort of critical of the Attorney General's press conference, pointed out the fact that teenagers try to see other teenagers naked. And that's not a good thing. And that's a situation that I think requires some adult intervention. I think it's an immature thing and a risky thing. And adults, there's an appropriate place for parents, maybe schools, counselors, things like that. Now, the case at Davies, and it's not, by the way, it's not just Davies. It's also multiple schools. I think when I talked to the Attorney General for my article that's up today as we record this on the 15th, I think the Attorney General said 4 other schools so far, or 4 schools total, I think is what he told me. But apparently it involves some much younger kids than the late. They're all kids, but much like the age gap. It's not like a 16, 17-year-old or 17, 18-year-old, something like that. It's much younger. That's obviously a very different situation. My criticism, though, was in holding a press conference and not a lot of distinctions made between the different serious levels of misconduct. A lot of emphasis put on protecting the victims, but I think the way the BCI handled it, not exactly doing a lot to protect the accused, or even just some who were just investigated because they happened to be innocent bystanders. I just thought it was handled poorly. And also the Attorney General coming out and talking about this, he's not in charge of making the decisions on the charges. That'll be the Cass County State's Attorney's Office. The BCI is a part of the Attorney General's office, but the Attorney General in North Dakota, although I think he can prosecute cases in some, generally is not a prosecutor. And so the investigation's not done. The investigation certainly hasn't been reviewed for charges yet. And yet we had a very, and I know the Attorney General objects to if I use the word sensational, but it sure got a lot of public attention. And I think has spurred a big public reaction and has now created a lot of public expectations from this case that may be unfair.
So Drew said in his article that you have up right now that he wanted to sort of squelch the rumors that were going around about this investigation. Did just the opposite of that. I mean, it actually brought more attention to it. And I think some of the parents that you talked to really talking about how their kids being marched around the schools with police in tow or investigators in tow, having Drew do a press conference doesn't squelch that rumor mongering. It pours fuel on it.
I can understand the concept of there being an information vacuum.
Yeah, I think what he's trying to do but it didn't accomplish that.
But I think you can solve that with a written press release that lays out certain facts that you're comfortable with releasing to the public, and then leave it at that. So I thought that was really, unfortunate. And also I think that from a larger perspective, a zoomed out perspective, we should be concerned. I mean, if I'm a state's attorney and there's like a big crime in my jurisdiction and the BCI gets involved, is the Attorney General going to ride in on their coattails and hold a press conference and Bigfoot me on this issue before I have a chance to even review the investigation is still with BCI. It has not been submitted to the Cass County. Now, maybe there's some coordination going on there or what have you. I don't know. I don't want to speak to that. But, I mean, I think this is going to, if this is how these things are going to be handled, I think there's the risk is that it's going to create friction between local prosecutors and the Attorney General's office.
Yeah, and let's be clear. I mean, this is all bad stuff. I mean, what they're investigating here is terrible stuff. There's a reason why several sessions ago, Senator Max Schneider sponsored and passed a bill outlining revenge porn. When folks would get pictures and then use it after the breakup or whatever. This is all bad stuff. But I think having law enforcement and politicians, politicians primarily, blowing this up doesn't help anybody. It doesn't help the victims, the accused, the schools, anybody involved.
I get criticism sometimes when I write about these things that I'm ignoring the victims, I'm not. I mean, if my child was in some of these images, whether they're real images or whether they're AI generated images, and they're being harassed or they're being whatever was happening there, I would be incensed as a father. I guess the tact that I take with these is that there's already a ton of people. Like, that's kind of where public sentiment is automatically.
Right.
And a lot of times what gets steamrolled in that are the accused or the people on the other side. And they deserve justice as well. Because, and by the way, not everybody who had their phone seized is going to be charged with anything. Because a lot of them.
I think that's the point, right? It's not even just the accused. It's just people who might have been buddies with somebody who is doing stuff illegally, who had their phones taken away as part of the investigation.
Or got an image or something because they're on a group text. Well, how do you stop somebody from texting you something?
Right.
I mean, you could block them after the fact. But once you've got it, you've got it. And now you're under an investigation. And now the police are walking you through the school and walking you out to your car and all these things. I just think there's a more sensitive way to handle it, particularly when there are kids on both sides of this thing. And I don't want to play the kids will be kids card, because that's not it. I mean,
it's serious stuff.
Even if it was a nude image that one teenager sent to another teenager consensually, and then it got spread beyond that, That's risky behavior that parents need to intervene on. I don't know if that particular situation deserves criminal justice treatment, but I think we could have been more sensitive to everyone involved here. And sensitive as we are to victims, we got to have those sensitivities on the other side too.
I know Drew's trying to protect kids. I mean, that's where his heart is. He's trying to protect kids, but sometimes interjecting yourself as the attorney general is not the right move.
It's not. We have a text, some reader feedback that was sent in regarding our previous discussion about applied digital. Mark from Fargo texts in. And by the way, if you want to leave a text or send us a voicemail, 701-587-3141. We love getting these. We love the feedback. Mark from Fargo asks, "Hi, Rob. Do you have a guest to discuss power discharge? Mentioned during the episode with Applied Digital CEO Wes Cummins as a guest. Reduced cost of unused, unstored power. Topic came up around 3645. Thanks, Mark." Now, Mark, I'm hoping I'm understanding your question correctly. I think what you're asking about is because one thing that Applied Digital was talking about specifically with Ellendale is that their demand, it was going to eat up unused capacity. Essentially, and I don't know what specific utility it is in Ellendale, but Minn Kota maybe, I don't know, but they essentially were capable of producing more power than that region was consuming. So Applied Digital came on, could essentially use up that extra capacity. And not only did it not raise rates, what Applied Digital said is actually lowered rates in that circumstance, because now this company has more business, they can operate more efficiently, and maybe some economies of scale there. I don't know. But I think that is an interesting question. How much, as these big consumers of energy, these big new customers for North Dakota Energy move into the market, how much excess capacity do we have? And I don't know I know we have some, and I know that increasingly, for political reasons, as some people don't want coal-fired electricity anymore. I don't know that there's a precise answer to that question. We have some, but I think that's a good question to ask. And I have said consistently, as I've heard people, if I've gotten feedback, I think the one really valid concern about the data centers is what's their impact on rates. That I think is and when I've talked to state officials, I think they're keeping a weather eye on that. They don't want to see, that would be a political disaster for them if rates through the roof. I mean, they'd see a voter revolt. So they are going to be very concerned about that. And but I think that is a completely valid concern. That is my concern as well.
I have the same concern. I think we should get somebody on from the utility that provides energy down in Ellendale to talk this through.
Speak even more broadly to the capacity in the state. I don't know who that is, but I'll figure that out, and I'll see about getting them on. Thank you so much for sending that in, though, Mark. And if I didn't completely answer your question, feel free to send another text or leave another voicemail, and we'll drill down on that. But that's actually a great idea and jives nicely, because that's going to be an ongoing discussion as well. All right, we're all done. Thank you so much, as always, for everyone for listening. I am trying to call us, leave voicemail. What's the number again? 701-587-3141. Is that what it is? Have I finally memorized it?
701-587-3141. You can follow us on YouTube, TikTok, Facebook, and X, which I still call Twitter, at Plain Talk ND. Coming up next week, we don't know.
Yeah, that's right. Maybe I am working on booking somebody from the local National Federation of Independent Businesses. They had
local national. I like that.
The local chapter of the NFIB, which is a national organization. They have a national poll. Don Larson, I think, is there. I think he's going to come on. We're going to find a way to get him on, whether it's next week. But they had an interesting survey about confidence, business confidence, talking about inflation and some of the things. That'll be interesting to talk to him about. Also, we're working on getting Senator Heidi Heitkamp. I think I had pitched that she was maybe going to be on this week. That ended up not working out. We'll get her on. Her group, it's, I don't know that it's her group, but it's the Brookings Institute and the American Enterprise Institute. So kind of right, left, These are two well-respected, very credible think tanks. One leans left, one leans right, talking about rural economies. Really interesting stuff. Working on getting her on as well. Thank you so much, as always, for listening. Chad doesn't even need me anymore. Chad did the whole outrow thing. You talk about how nervous you are about running the ship on your own, and you're a pro.
So here's the thing. I'm nervous when I have to plan to run the show on my own. If I can just like jump in like that.
Dunk on me a little bit. Show me up.
Yeah, here's the deal. I like to be prepared.
For sure. I always lose track of where the phone number is. And here it is. I just found it.
Here's the deal. I happened to look to my right, and it was on the top of my great episode brief that we get from Matt. And so I was at the
when I did radio, I had to have the call-in numbers plastered above my monitor, because as many times as I had to repeat them over and over again, I would be going out and I'd be trying to remember them. I just needed a place where I could look and read them and have it there to remind me. But who knows? The human mind is a mystery. Maybe
it is.
That on another show. Thank you so much for listening. We'll talk again.
Go Dodgers.
That's it for today on Plain Talk, the voice of North Dakota politics. Plain Talk is a production of Forum Communications Company. Got a question, comment, or suggestion? Leave us a voicemail or send us a text message at 701-587-3141. That's 701-587-3141. If you haven't subscribed to Plain Talk yet, you can find us on YouTube or your favorite podcast platform like Spotify or Apple Podcasts. For those of you who are already hooked, give us a rating or review. And don't forget to share or tell a friend. Special thanks to my co-host Chad Oban, and from myself and everyone at Plain Talk, thanks for listening. I am sensitive about baseball, man.